Hello, everyone. Welcome to our session three for discussing the hypertension. We have Dr. Sushanta Goswami with us, and he is MD in internal medicine. He already discussed earlier um, episodes on hypertension. So today we'll be taking the discussion forward. Dr. Goswami, you can start.
Hello, this is Dr. Goswami. I did my MBBS from SCB Medical College, Cuttack, Odisha, followed by MD in All India Institute, New Delhi, followed by a residency in New York, followed by nephrology kidney disease fellowship in University of Oklahoma, followed by a transplant medicine fellowship in University of Houston Methodist attached to Well Cornell University. This is the third session of hypertension, and special cases we will discuss and what are the complications of hypertension and how to treat each of them. First of all, I wanted to tell you about three things we must know about hypertension, that what kind of bad side effect it can bring to us if we are not serious about it. Number one is hypertensive urgency. Anytime the blood pressure is more than 180 over 120, you are going into the phase of hypertensive urgency. In this, there is no organ damage, but the blood pressure is good enough to make organ damage. So this is the window period we can treat the blood pressure, bring it down so that we don't get into organ damage. Number two is hypertensive emergency. This is same as hypertensive urgency, but with organ damage. It is a next step from hypertensive urgency to hypertensive emergency. In this case, blood pressure is always more than 180 over 120, and you have organ damage evidence like stroke, heart attack, kidney failure. Those are the organ damage. I'll go in detail. In that case, you need to admit the patient right away and give IV medication to bring the blood pressure down, because it's already damaged your organ. You don't want further damage. Number three is malignant hypertension. If hypertensive emergency is not controlled, organs are damaged, it can go further damaging the organs, and something is called malignant hypertension. Here, the blood pressure reaches the level of 240 over 140, and that will affect your eye. Your vision will be disturbed. You may be blind. There will be hemorrhage on the brain, and there will be tearing of your aorta due to sheer high force of the blood pressure. You need to be admitting to the hospital and into the ICU and get IV drip to control blood pressure in minutes. Usually, the blood pressure is controlled over 1 day and then over 1 week period, from the higher end to the normal end. But only exception is hypertensive emergency and malignant hypertension, where you have to control the blood pressure in minutes. Okay, how to control the blood pressure? And there is another term I wanted to tell you called resistant hypertension. Resistant hypertension means you are taking, the definition of this is you are taking 3 blood pressure medication for 6 months and you are not able to control the blood pressure. You are not achieving your goal. One of the medication has to be a hydrochlorothiazide or chlorothalidone. So how to approach to control the blood pressure first? In general, the first thing to control the blood pressure is to bring the blood pressure from 180 over 120 and over down to 160 over 110 range within 1 hour. That means what happens in 1 hour? You should control the blood pressure, especially the systolic, by 10% down. What happens? There is a auto-regulation of the blood pressure. When the blood pressure goes up, the body tries to regulate its blood vessels in such a way they go into spasm so that the blood pressure doesn't cause full effect and doesn't cause bleeding or any stroke, because the blood pressure force is kind of compensated from the vasospasm. So the full effect of blood pressure is not transmitted to the brain or heart or kidney. So this is a protective mechanism. When you have a protective mechanism, it tries to squeeze the blood vessels, cause spasm, and the blood circulation is affected enough. If it continues for a long time, you might have stroke. You might have kidney failure because the blood flow is not going to the kidney. Your kidney function will go down. Your brain function will go down. You will have stroke. Your heart function will go down. You'll have heart attack because you are getting vasospasm. This is called autoregulation. Autoregulation has a good thing or bad thing. Good thing is that it prevents high blood pressure transmitted to the different organs, causing major damage. The bad side effect is because it causes vasospasm, it's cut down the circulation and the organs will be affected in a way. If it continues for a long time, due to lack of blood supply, they will have hypoxia and organ damage. So when you reduce the blood pressure 10% in the first 1 hour, that auto-regulation, it that means your blood pressure is good enough that blood vessels doesn't have to go into spasm or constrict to protect you. Our plan is to bring the blood pressure 10% down in the first 1 hour so that the auto-regulation is gone. The auto-regulation effect there will be no auto-regulation. And then in the next 23 hours, we are supposed to bring the blood pressure another 15% down. For example, if the blood pressure is 180 over 120, when actually the problem starts, we need to bring down the blood pressure 10% down. That will be around, blood pressure should be 160 over 110 in 1 hour. And then another 15% down in next 23 hours. That means blood pressure would be around 140 over 90. So in first 1 day, which is 24 hours, our blood pressure should be down by 25%. That is the best way of blood pressure monitoring. And then we can, sometimes it takes 1 week to control the blood pressure slowly. If the blood pressure is too high, you can't achieve 140 over 90 within 1 day, but try to bring it down to 160 over 110 in 1 day. And then over a week, try to get down slowly to 140 over 90 by increasing the dose of the medications, by other methods, by your lifestyle modification. You have 1 more week to work on to get the blood pressure down. This is the normal way how to blood pressure control within a week. But if it is hypertensive emergency with organ damage and malignant hypertension with organ damage, you need to admit and give IV medication to get blood pressure controlled in minutes, not in days. So these are the most important thing. And now we are going to go to the complications of the blood pressure. What are the complications can happen from high blood pressure? Number one is brain. Number two is heart. and blood vessels. Number three is kidneys. Number one is brain. What does it do in the brain? So it causes stroke, bleeding, and you lose your vision, become blind, confused, and if multiple times you have high blood pressure and stroke, multiple stroke will damage your brain in such extent that you will have dementia called vascular dementia. You'll start forgetting things. Second thing is heart. What does it do it in the heart? When the blood pressure goes very high, the pressure is so much that it rips off the part of the aorta. So the aorta has three layers. The inside layer called intima, it kinds of cut off as if you are running a blade inside of the aorta. The blood pressure will kind of tear off the part of the aorta, and then you will have aortic dissection that need a surgical correction. So you need to control blood pressure in minutes. Try to keep the blood pressure around 100/60 when that happens. Another thing happens in the heart when the blood pressure goes up, it puts so much pressure on the heart can't pump the blood anymore, goes into heart failure. And the blood vessels, the heart and the lungs, everything get filled with fluids. There's a backward flow from the heart to the lungs, then the abdomen gets swelling, then the legs get swelling. Everything is like waterlogged system. As if you're putting a dam in front of your heart, the blood pressure is putting so much pressure in front of the heart that the heart can function. Everything is backlogged. You're having like overflow, a flood behind your heart. Your lungs will full of fluids. Your abdomen will have full of fluids. You will have ascites. Your legs will be started swelling. You will have pedal edema. All those symptoms of congestive heart failure will happen over the course of in months. Another thing happens in the heart is because the blood vessels are going into spasm to protect as an autoregulation mechanism from high blood pressure, you will have a lack of blood supply to the coronaries, your heart circulations. If your heart already had like cholesterol plaques or some blockage, then when it goes into spasm, you will have a heart attack. That's called myocardial infarction, chest pain, shortness of breath. All this will happen from the effect of the hypertension. Now, another thing, now next is kidney. What does it do to the kidney? When the blood vessels spasm due to high blood pressure, it shuts up the circulation to kidney. And it's called kidney goes into kidney failure. There are stages of kidney failure. Stage 1, 2, 3, 4, 5. 5 means you will be on dialysis. Your kidney is not working, not making any urine anymore. So we need to control the blood pressure enough that this doesn't happen to kidneys and the kidneys are protected. Then there is another term. If your kidneys are bad, then they have a system in the kidney called RAS, RAAS, renin, aldosterone, renin, angiotensin, aldosterone system. This system is in the kidney. Once the blood pressure kidney starts failing, that will increase, that will stimulate the aldosterone renin system and will increase the blood pressure further. So it's like a vicious circle. Your blood pressure gives rise to kidney problem gives rise to RAS activation gives to high blood pressure. So it's continuous a circle. You have to break that circle, bring the blood pressure down, and the cycle will break. Those are the main side effects of blood pressure. But now we'll go to individual details. There are 10 points I'll discuss. One is congestive heart failure. I have told you about how it does, how high blood pressure can cause congestive heart failure. Now they have four stages of heart failure: stage one, stage two, stage three, stage four. Different stage needs different medication for blood pressure control. When the heart goes to too low of heart rate, like the heart only works 20% or less, by then you already start with AC inhibitors, diuretics, there's a special kind of beta blocker called carvedilol. That usually beta blocker are contraindicated in heart failure, but this particular beta blocker works good because it has an intrinsic sympathomimetic activity. It contracts the heart, and also it has a beta blocking activity. It controls the heart rate. So it increases the function of the heart by sympathetic activity. It decreases the heart rate by beta blocking activity. So it has a both beneficial effect from alpha and beta receptors. Um, the congestive heart failure, you first start with ACE inhibitors, then nitroglycerin drips, which cause vasodilatation, and blood pressure will be down. And then the beta blocker I told. Then the diuretics. Your heart is filled with fluid, your lungs are filled with fluid because of heart failure, you need to give diuretics to control the fluid situation on the heart. Number two is acute coronary syndrome, otherwise known as angina or heart attack. You need to give special beta blocker called cardioselective beta blockers. I told you they are atenolol, metoprolol, bistolic, esmolol, nebiviol, betaxolol, all those things. Cardioselective beta blocker is very good for angina and heart attacks from high blood pressure, plus nitroglycerin tablets under the tongue to relax your blood vessels in the heart to stop angina. Then you give aspirin on the top of that. Second, the third thing is stroke. Stroke, the best blood pressure medication is amlodipine, is a kind of calcium channel blocker. But if somebody has a stroke, then there are two things. One is a high blood pressure can give rise to stroke, or it can give rise to pre-stroke. That is not stroke yet, but you're feeling like you are having a stroke. But if you do CAT scan or MRI, there is no stroke. So you are one step behind. And that is the time you need to control the blood pressure. And that's the best blood pressure medication is amlodipine, a calcium channel blocker. But you have already stroke, then you don't treat blood pressure unless it is more than 220 over 120. You have already had a stroke, you don't get the blood pressure down. You need to keep it, if it's 220 over 120 and less, you don't need to treat blood pressure because you have already stroke. If your blood pressure is too down, that means you won't have any circulation to your brain because your autoregulation on the brain blood vessels, they're going to spasm. So if you don't have enough blood pressure, you won't transmit blood through the vessels to the brain. And as a result, you'll have more stroke. So we don't need to decrease the blood pressure in stroke patients unless it is more than 220 over 120. But if a patient, you think patient comes within 3 hours or 4 hours of stroke, sometimes we give an injection in the body called TPA. And those injections can stop the blockage in the brain and lyse out the blockage in the brain, and the stroke will be complete, will be cured. And those things, for that condition, special conditions, if the patient only comes within 3 to 4 hours of stroke, then we can cut down the blood pressure. We have medication to bring the blood pressure down 185 over 110, and then give this injection, which will cause the lysis of the blockage in the brain, and the blood pressure and the stroke will be completely reversed. But if the patient has stroke and come after 6 hours, those things don't work. We cannot give you any um, TPA injections to reverse stroke. So you have to then don't treat the blood pressure, keep it 220 over 120, and keep the blood pressure a little higher. Don't treat it, and once the stroke is getting better with aspirin and other things, then gradually we'll get down the blood pressure over a week. So those are the things we get. And then another thing I'll tell about another special situation is pregnancy. Pregnancy, if somebody is pregnant, there are 5 kinds of blood pressure happens in pregnancy. The most important is pregnancy-induced hypertension, in which case we don't treat blood pressure unless it is more than 160 over 110. Because in pregnancy, blood pressure usually is controlled by itself because of the estrogen, a lot of estrogen production during pregnancy that helps to relax the blood vessels, and the blood pressure is controlled. But if the blood pressure is more than 160 over 110, we need to control the blood pressure. Or if the blood pressure is 150 over 110, plus patient has low platelets, the platelet starts decreasing less than 100,000, then you have to control the blood pressure. And what are the best medication for blood pressure in pregnancy? Number 1 is labetalol. Number 2 is methyl dopa. Number 3 is hydralazine, but we are trying to get rid of that because it causes reflex tachycardia and problems with the baby. So we are trying to not give that unless it is a third choice for the blood pressure in pregnancy. Then number thing is, so these are the things we have already discussed. The last one I want to discuss, and then we'll go for questions. The last thing we have is called PRES, P-R-E-S, posterior reversible encephalopathic syndrome. This is due to high blood pressure. When blood pressure goes up, it is mostly the occipital, the back of the head is the one which is affected the most. And they have done a MRI and CT scan to show that if the blood pressure goes up, at what level, before it gets into stroke level, what are the other changes can happen on the brain due to high blood pressure. So the first change they have found out is called PRES, posterior reversible encephalopathic syndrome. What they found, they did a CT scan and MRI, they found there is a edema and swelling on the back of the brain, mostly in the occipital lobe and parietal lobe, posterior part of the parietal lobe. So the blood pressure goes up, the blood vessel goes into spasm, trying to protect hypertensive effect on the brain and kind of decrease the circulation to the brain. And as a result, they become hypoxic. Once the tissue become little hypoxic, they become edematous and swelling. Now those are the first symptoms we see. By then, patient will have some confusion, headache on the back, called occipital headache, and maybe have some vision changes and dizziness, but no stroke. You won't have any paralysis or anything like that. Those are things. If we if you control the blood pressure right away and bring the blood pressure down to less than 160 over 110, then those changes will be gone. So this is called press syndrome. That is a pre stroke effect of the brain that is reversible completely. So you check control the blood pressure, this will be all gone. If you don't control the blood pressure, then we'll start going to the next phase, stroke, TIA, bleeding in the brain. All this can happen from the high blood pressure. Um, so basically, these are the things I have discussed. The medications, what are the special medications that we can give on the blood pressure if it's high? We want to control the blood pressure within minutes. We admit the patient to ICU and you start on drips. The most important drip is labetalol. It is usually given 2 milligram per minute drip, or you can give 10 to 20 milligram IV every 6 hours. Next thing is hydralazine, which is given 10 to 20 milligram IV to 6 hourly. Next thing is called nicardipine drip. Another medicine is called nitroprusside drip. Those are the drips that control the blood pressure within minutes. And those are the emergency medication for high blood pressure control. Now I have discussed most of the medications. Now,
So we have questions. If
you have any questions?
Yeah, so the first question is the how to control postural hypotension.
Hypo. So I'm talking about hypertension.
Okay, maybe some other time.
Hypertension is a different, it's a completely different topic. We can discuss when we go into hypotension.
And there is another question regarding the maximum daily safe dose for telmisartan for patients who is more than 70 years of age. So I saw the telmisartan dose is around 40 mg and highest dose is 80 mg. But I think when
Okay.
the patient is aging, geriatric patient, so what changes may happen and should we still go for 80 mg or we should see other conditions like liver function, kidney function, then decide the dose if you can tell something about it.
Okay. So the most common medication we use is SC inhibitor or ARB. Now the telmisartan is a ARB called angiotensin receptor blocker. What are the side effects of telmisartan that we can't use? Those are the things you have to know. Number one is kidney failure. Sometimes telmisartan can cause the increase in creatinine and decrease the renal function, and the GFR, glomerular filtration rate, will decrease. That means the renal function are slightly decreased because of telmisartan. So we check the blood creatinine level. If the blood creatinine level is more than 1.5 in a male and more than 1.4 in a female, then we have to be cautious about using the telmisartan. So we cut down the dose. If it is taking 40 milligram, we cut down to 20 milligram and add something else like a calcium channel blocker or a beta blocker so that it doesn't have a full side effect of telmisartan. Will be contented with half dose of telmisartan, and so that the kidney function doesn't go down further. But in diabetic, I have seen the book recommends that you can give telmisartan until the creatinine goes all the way up to 2.2. 2 or 2.2, because in diabetic, the S inhibitors and ARB, they are the most valuable medication for blood pressure in diabetic control and proteinuria control as a effect of diabetic nephropathy. So even if the creatinine is little up, even if the kidney function is little down, we still can continue telmisartan dose um, um, until the creatinine goes all the way up to 2.2. Otherwise, and then we can cut down. But if we don't have diabetes, we can always cut down if the creatinine goes more than 1.5 or 1.8. So we'll monitor the creatinine level in the blood, the kidney function level in the blood, the glomerular function rate, GFR in the blood test, and then we can adjust our medication as it is. Otherwise, there is no age uh, criteria, is all the laboratory criteria. Then another side effect of telmisartan is hyperkalemia. Potassium will be high. So in those cases, we need to take a low potassium diet. Which are the diets high in potassium? Banana, avocados, tomatoes, grapes, all the fruits. They are spinach. They are high in potassium. So try to stay away from those foods. Don't take any potassium supplement and try to cut down the dose of telmisartan enough that the potassium level don't go more than 5. That's the main thing we try to look for when the potassium level is high and you are using telmisartan. You have to cautious. Those are the main two things.
We
One
have
is kidney functions in the measurement of creatinine in the serum, and second one is the potassium level in the measurement of blood potassium level. Those are the things which will direct how to dose telmisartan.
okay, thank you. We have approximately 2 minutes left for this meeting, and we can take one last question is how to control early morning abnormal hypertension. In this case, systolic hypertension is more than 155 Hg.
Okay. First of all, you want to see early morning hypertension. Is it happening in the morning or it has been happening throughout the night? You need to check blood pressure at 10 o'clock or 11 o'clock the night or 12 o'clock in the midnight when you go to bed. If the blood pressure is high in the night and also high in the morning, that means you need a nighttime dose or a longer acting blood pressure medication like instead of hydrochlorothiazide, you need chlorothalidone. That will control your blood pressure little longer time, half-life of 20 hours. So it will continue throughout the night and the blood pressure will be controlled by morning. These are the main things, those where the blood pressure will be high. This is called masked hypertension. All you are telling about is called masked, M-A-S-K-E-D, masked hypertension. Usually what happens in the blood pressure, when people goes to bed in the night and they're relaxed and sleeping, the blood pressure goes down. It's called dipping. So nighttime blood pressure should be down. It's called dipping, D-I-P-P-I-N-G. If there is no dipping of blood pressure in the night, that means it's called masked hypertension. That means the patient has stress. Patient blood pressure is not controlled with usual medication. You need to give a longer acting duration medication that will control the nighttime blood pressure. And that will eventually, the morning blood pressure will be also
So,
down.
so if the hypertension is 140 at 1 a.m. and morning
Mm.
it's 155,
Mhm.
then what is the
So blood pressure vary time to time. So you don't have to worry about 2 millimeter, 5 millimeter variance. It will vary. You know, if you are stressed out, you are running, jogging in the daytime,